Thanks everyone for showing up. Sorry for the little bit of delay, but so happy that you're all here with us. I see you guys are kind of chatting a little bit, and I want to know, Michelle, why are you so nervous? Already having anxiety because you're here, you're learning, and we're all going to take you from wherever you are in your preparedness and hopefully level you up and elevate your NCLEX readiness just a little bit. So I'll ask you guys, if you had to, this is my favorite question to ask students, on a scale of 0 to 10, how prepared do you feel to take the NCLEX tomorrow, if you were going to take it tomorrow? And okay, Iberia says, the fact that I don't know if I'm doing it right gets me anxious. That's a really good point. And that is really our whole kind of plan at NCLEX Bootcamp, is to make sure that you have enough opportunity to practice with these until you get that confidence and you're like, I know what I'm doing. So one thing that a lot of people don't realize about the NCLEX is the way that the computerized adaptive testing works means that every single question you get, or I get, if I was to sit down and take it, it would feel like one that I've got a 50% chance of answering correctly. So in one sense, if you're answering hard questions and you feel like you're guessing, that actually means you're probably passing the NCLEX because you're challenging yourself to answer those passing level questions or higher. So don't be discouraged or let it throw you off if you feel like you're guessing or you don't feel like you know what you're doing. Instead, I would encourage you to kind of get comfortable with that feeling. And so we're going to go through some questions today. But wow, there's a big spread. Michelle says 0 preparedness. A lot of people said 0. And then a bunch of you guys said between 5, 6, and 7. So, all right. So we got a good spread. Hopefully those of you that have come in today and you're at a 0, you leave it higher than a 0. And hopefully you'll get something out of this, because we are going to talk about how to study for the next generation NCLEX. And I am Dr. Emily, one of the co-creators here at NCLEX Bootcamp. And we have another nurse from our team in the moderator comments to kind of help. If you guys leave any questions, she's going to try and answer them. If it's something that she thinks I could answer for you, she's going to let me know. And so please feel free to drop your questions, comments, and we will do all of this together. But so yes, this is me, Dr. Emily, and I'm excited to talk to you guys today about how to study for the next gen NCLEX. And in order to do that, to understand that, you need to look at the purpose of the NCLEX. What are they even trying to figure out by administering the NCLEX? Then we're going to look at what the top 5 NCLEX topics are. And we're going to spend most of our time today doing some live question practice, because again, practicing answering questions is the best way to convince yourself that you do know what you're doing after all, Michelle. So first, what is on the NCLEX? And there is actually an official NCLEX test plan. You can go to the NCSBN website and review this. They have detailed statements about each of these client need areas. So for example, something about using hand hygiene for infection control, checking 2 patient identifiers for safety. So the NCLEX actually tells us what's on the test. And based on a practice analysis survey, where practicing nurses submit and answer a survey saying, here's the things that I do every day and here's how important they are, they're going to give you more questions that test those things that are really important, that you're doing really frequently. So this is meant to be representative of real nursing practice. What are the things that are keeping our patients safe? Is about 13%. That's helping manage or direct the care at that unit or system level. That's your prioritization, delegation, assignment, keeping everything running. Health promotion and maintenance, so assessing whether children are meeting developmental milestones, making sure that women are gaining enough weight during pregnancy, vaccine prevention, things like that. Psychosocial integrity, so your therapeutic communication. Basic care and comfort, that's your skin care, mobility. Pharm, everyone's favorite. Reduction of risk potential, so preventing complications of surgeries or procedures like Foley catheter insertion. And then physiological adaptation, which is kind of the bread and butter of how to assess and manage diseases as a nurse. But that seems like a lot, but actually these 5 topics make up over 70% of the exam. So 24% of your exam comes from clinical judgment. This is new for the next gen NCLEX, where they test your ability to think like a nurse, and they do this using the case studies. Management of care, farm, physiological adaptation, and safety and infection control follow. But you can see that the big one, far and away, is clinical judgment. And that is why it is so important to have a lot of practice with really high quality case studies that are actually representative of the real test. So I'm just going to check for questions before we move on. It doesn't look like anyone has any specific questions yet. So we'll move on to talk about the clinical judgment measurement model. And this is the 6-step process that the NCLEX uses to outline how a nurse thinks. And yes, this is going to parallel your 6 questions on a next-gen case study. And so you're going to get 6 questions in a row, and each question is going to correspond to one of these steps. And these terms might not be familiar to you guys, but this pretty closely correlates with the nursing process, which you should be familiar with. So I'd also like to ask you guys, how many of you learned this in school or in some way, maybe in class, you went through these 6 steps for a certain disease process? Or is this just brand new to you guys? So have you seen this before or not? But we're going to talk through each of these steps one at a time. So again, the next gen is going to put these into their case studies. They're going to have 1 question per step. But just for the sake of going through all 6 steps today without making you guys read through a full case study, we have chosen some of our most popular standalone questions from our bank that best represent each of these 6 steps in clinical judgment. Because at the end of the day, the NCLEX is really all testing our clinical judgment in clinical scenarios. So first up is recognizing cues, or being able to identify what's most important. Because real life isn't like just one simple standalone question where we've got one piece of patient information in the stem and you're going to have 5 items on your patient's history list. They're on 10 medications. They have 3 things they need right now, and one of them is always a turkey sandwich, right? And so you have to be able to identify what's most important so that we can recognize and spend our time on that. And so we're going to look at this question that's testing what's most important. And in this case, we're caring for a client who has severe COPD, and we're asked which of the following findings would require immediate follow-up. And so in all our patients, they're going to have some pertinent positive findings. Some of them are going to be expected abnormals, and some of them are going to be unexpected abnormals. And so it's our job to figure out which of these are expected based on this diagnosis of COPD, or which ones do I need to immediately follow up on. And while you guys think and drop maybe some of your guesses here, all right, it looks like actually a lot of you have learned this. So I'm glad to hear that because, okay, so you guys have learned the clinical judgment model before in class, some of you in your NCLEX prep stuff. Very good. And I see that a couple of you guys are guessing and throwing your guesses in the ring. So, okay, let's talk through this. So remember with COPD, we're going to have a chronic airflow obstruction. So mostly smoking cigarettes is what's going to cause this inflammation and excess mucus that prevents air from getting in, and it's going to destroy the alveolar membrane's elasticity so that when they try to exhale, instead of pushing the air out, this is just going to collapse. So we can't get air in and we can't get air out. And this is going to cause several systemic findings beyond just pulmonary. So let's take a look. Lower extremity edema. And I don't see that anybody guessed this because yes, you're right, that is expected. That is an expected finding because when you have hypoxic lungs, they vasoconstrict, and that means the pressure is raised in the lungs, and so the right heart really has to work very hard to pump blood to these lungs that are already struggling. And so as the right heart starts to fail, the patient can develop heart failure and get some lower extremity edema from that, because the right heart is going to back up systemically. So that would be a concerning finding, yes, but the most scary finding for fluid overload is maybe crackles in the lungs, right? And I don't have that. I just have lower extremity edema. So if I was going to immediately follow up on that, all I would do would be elevate the feet. So doesn't really feel urgent to me. And so let's move on. And so far, everyone has guessed option 2, and I'm very proud of you guys because that is the correct answer. Paradoxical respirations, if you ever see this on the NCLEX, it is never normal. This is an unexpected abnormal finding. And what happens here is your patient is so fatigued from their work of breathing that they start to suck in their breath and push it out. Normally, our chest rises and falls with breathing, but they will have the opposite movement. And so that indicates they're wearing out, and it is really scary to see someone who is getting too tired to breathe. So that would require immediate follow-up. But let's see what might have confused us about our other ones. So the increased hemoglobin level, that one is, remember, we have chronic hypoxia. That's what caused the vasoconstriction and heart failure. Also, that chronic hypoxia is going to cause your body to try and compensate. Your organs aren't getting enough oxygen, so your body increases the production of red blood cells to try and just carry more oxygen through the blood. So you're going to see an increased hemoglobin level, and that's called polycythemia vera, and that's an expected finding as well. And then a pulse oximetry reading of 88%. Nobody selected this, but you guys might encounter this distractor on the NCLEX, and this is because our patients with COPD are chronically hypoxic, and they tend to live a little lower, and when we're giving them supplemental oxygen, we want to titrate that to keep their pulse oximetry reading between 88 and 92%. And so I really wouldn't even increase the oxygen for this unless they're dipping or they're, struggling. And so, yes, you guys are right. Paradoxical respirations are the thing I would follow up on. And everyone chose that answer, which is amazing because in our question bank, only 57% of thousands of students chose this correctly. So you guys are rocking it. You're ready for this. Great job. Okay, next question. So then after you recognize the cues and figure out what's most important, you need to analyze those cues to figure out what could it mean. You're going to have, in the example of shortness of breath, if I have shortness of breath with a fever and a productive cough, that might mean pneumonia, right? But if I have shortness of breath and a swollen left lower extremity that's tender and hot to the touch, and they have hemoptysis and tachycardia, that shortness of breath, that cue is going to mean something different. And you should leave your comment if you guys know what it is. So in this example of interpreting the meaning of cues, analyzing cues, we got the nurse is caring for a client with suspected chronic venous insufficiency. So which of these findings would support a diagnosis of chronic venous insufficiency? Either an absent pulse, intermittent leg cramping with exercise, ulcers on the toes with well-defined edges, or a brown discoloration to the lower extremities. And Amber's guessed number 2. We've got some guesses for number 4. And all right, so let's talk through this one. So this is something that the NCLEX loves to test, is venous versus arterial problems, because they're going to look different, and a lot of the management for this is really on the nurse. So we need to identify which of these findings would be more arterial insufficiency or venous insufficiency. And so an absent pedal pulse, if we're not getting enough blood flow to the lower extremity, we're not going to feel the pulse as well. So that's a finding of arterial insufficiency. Then intermittent leg cramping with exercise. I think a couple of you guys have guessed this one. And that is also something that happens with arterial insufficiency. It's called intermittent claudication. That's because they're walking, their calf muscles are using up all of the oxygen, and they have arterial insufficiency. It can't supply more blood. So they start to cramp as that lactic acidosis builds up. Ulcers on the toes. With arterial insufficiency, the blood flow is going to be worse the further down on the extremity it is, because that's where it's getting the least blood. So with arterial insufficiency, you're going to see ulcers on the toes and really far down, whereas with venous insufficiency, they're going to be higher up on the leg, more like the ankle or the calf. So yes, you guys are right. Even if you weren't familiar with what this is, you can kind of eliminate all the other answers because you know they're arterial findings. And this brown discoloration to the lower extremities, like you can see here, is what's consistent with chronic venous insufficiency. And this happens because with chronic venous insufficiency, you have pooling of blood in the lower extremities. And our red blood cells, wherever they are in the body, they're all the time just dying, and new ones are being put out to replace them. But they have to actually circulate back up to your body, to your spleen, to get recycled. But when you have chronic venous insufficiency, that doesn't happen. And so these byproducts of normal hemoglobin breakdown leak out into the tissues, and hemoglobin contains iron, right? So this is called hemosiderin deposits. You actually have this iron kind of staining of the skin, and I like to think of it like it's rusting, like the blood is just pooling there, and so it's got this rusty kind of appearance. So very good. Although you guys kind of switched and guessed 2 or number 4, most of you guessed number 4, and again, about 50% of our users got this correct, so very well done. All right, the next we're going to look at prioritizing hypotheses. So now that we've analyzed the meaning of our cue, we're going to prioritize and decide, where do I start? Because again, like we talked about, you always have so many things to do at once. And so what do I need to address first? What do I need to prioritize monitoring? What do I need to treat like it's most important? And so let me ask you guys a question. If you had a patient that just had a craniotomy, so they just had brain surgery, and they come into you've admitted them to the ICU, what complication is a priority that you're going to monitor for? So they come out of the PACU, they've just had a craniotomy. What complication do I prioritize monitoring for? Okay. All right. A couple people guessed level of consciousness. Somebody said IOP. I think you mean ICP. All right. So let's see. I agree with you. When our patient comes out from a craniotomy, we are going to prioritize looking at increased intracranial pressure. And so when I want to prioritize my assessments, we're going to have some assessments that are more useful than others, because you guys got it. ICP is the most important thing. So which of these assessments should we prioritize? And you guys have all guessed ICP, bleeding, level of consciousness. Yes, Trisha, if they have bleeding in the brain, it's going to look like increased intracranial pressure. Lisa Bling says clear drainage from the nose, right? That might be a CSF leak. Yes, these are all things that we should be thinking about. And increased intracranial pressure is kind of the big one. This is the classic one that you're going to get asked about in the NCLEX. So which of these assessments would we prioritize? Which is going to be the most useful for us to monitor increased ICP? And it looks like a lot of you guys are guessing 4. And yes, I would agree with you. So level of consciousness, don't ever forget this. Level of consciousness is the earliest and most sensitive indicator of increasing intracranial pressure. So it's not pupils. If we're checking their pupil size and reactivity and they already have blown pupils, that's a really late sign, right? So it's too late. And level of consciousness, you can assess that from the doorway. You can look in at the patient and tell that. Whereas pupil size and reactivity, you actually have to go to the bedside, shine a light in their eyes. It's not something you're kind of always doing in the back of your mind. Presence of headache, you could definitely have a headache with an increased intracranial pressure, but you could also have a headache because you just had a craniotomy. So this isn't going to tell us necessarily that there's a complication. And then nobody selected the Babinski reflex, but yes, that would actually be more useful to tell us about a spinal cord injury, not increased intracranial pressure. So you guys got it with level of consciousness, and 80% of our users got this right. So this is one of those need to know things. So if you didn't know it before, now you'll remember it forever, I hope. All right, then after we've prioritized, actually before we move on from prioritization, if prioritization is something that you guys struggle with, I want to remind you that we've got our new NCLEX cheat sheets available. And our prioritization cheat sheet, you can see our prioritization pyramid here. We've got some starred points that are really important to help you guys understand and practice with some prioritization questions, delegation and assignment questions. And our moderator is going to leave a link for you in the comments to where you can go get access to some of our cheat sheets for free if clinical judgment, prioritization, things like this are something that you struggle with and want a little bit more practice with. You can check out our free trial and our free cheat sheets that are available to you. Then next, we're going to generate solutions or figure out, what can I do? Now that I've prioritized this problem I want to address, what can I do about it? And in this case, we've got a 68-year-old male who just underwent a coronary angiography via a femoral artery approach. which interventions should we anticipate? Select all that apply. So we need to figure out which interventions to anticipate after a coronary angiography. And here is a tip for select all that apply questions. You want to select all that apply. I know that seems too simple, but whether that's one of these 5 options or all of these 5 options. If any instructor or NCLEX teacher or anybody told you that it has to be at least 2 but never all of them, that is an old rule for the old NCLEX. On the new NCLEX, it can be 1, it can be all, and it can be anything in between. You just want to select all that apply. And the best way to do that is to treat each option as if it's its own true or false statement. So you guys should know, and I'm going to ask you to leave in the chat box, what is a coronary angiography done to treat? And I see some of you are dropping some answers already. You guys seem to like 2, 3, and 5. All right. Okay, coronary angiography. So coronary angiography is done to treat coronary artery disease, right? It can be done emergently if someone is coming in with unstable angina, and they're going to go in and actually visualize under x-ray. They're going to inject some dye inside the coronary arteries and visualize where a blockage is and open it up. So we might do this emergently to treat unstable angina. We also might do this routinely to diagnose the severity of someone's coronary artery disease, and we might place a stent and leave a stent in place. And so you guys are all kind of guessing similar things. Very good. So let's treat each of these like a true or false. Do I want to place the client on a fluid restriction? And I was going to say nobody's guessed this, but somebody has guessed this. And don't fall for this. Remember, when we've given IV contrast, we've injected a lot of IV contrast into the coronary arteries, into their bloodstream. What organ hates contrast? There's an organ in your body that will absolutely act up and even fail if it gets too much contrast and not enough fluid. Yes, Hannah says no because of the dye. And Hannah, you are correct. That is exactly right. When we give contrast dye, that is one of the most, actually I think it's the most common cause of intrarenal acute renal failure, is if you have contrast nephropathy, or giving contrast dye damages the kidneys. So we don't want to give contrast dye to any patients that have renal failure or an elevated creatinine. And even patients who have healthy kidneys, when we give them this much contrast, they get a ton of fluids to flush that out and protect their kidneys. So we're not putting them on a fluid restriction. We are going to be giving IV fluids and oral fluids to try and flush that out. So well done, you guys. Beverline, Luange, Mona, Oman, Sunny Duh, you guys all guessed kidneys. Well done. Yeah, don't forget it. So this is not correct. This is a false statement. Then all of you have guessed monitor the puncture site for swelling. Yes. So in this procedure, remember what patients get when they come in with chest pain is they get a ton of aspirin, right? And we put them on a heparin drip, and we basically give them a ton of blood thinners and then go puncture one of the largest arteries in their body. So they're going to be at really high risk for bleeding. But because it's so deep in the body, we might not see actual hematoma or bruising. It might just look like local swelling. So yes, we're going to monitor the puncture site for swelling. Very good. Everyone guessed to place them on continuous cardiac monitoring? Definitely. So not only did this person likely just have some kind of coronary event, but we kind of went in there and tickled their coronary arteries. So we don't want to have irritated anything. We also don't want that stent that was placed to accidentally collapse, and then we would start to see ST changes again, right? So definitely we're going to put them on cardiac monitoring. Then assisting them up to the chair to prevent atelectasis. And I'm seeing a lot of you guys guess number 4. And it sounds like a good idea. We want to prevent atelectasis, but we do not want in the initial post-procedure care to get this patient up, because remember, we just punctured their femoral artery. They have to stay on bed rest with their legs straight for a certain number of hours. And I think those of you who got this one right will probably know. So how long does a patient have to stay on bed rest? after a femoral artery coronary angiography. But in the initial post-procedure care, we are not getting them out of bed. We don't want them to bend that leg. We don't want them to bend forward at the waist. We don't even want them to cough or do anything that increases the abdominal pressure too much, because that is just going to put pressure on this groin site and they could easily bleed to death. And you guys said, somebody said 6 hours, somebody said 12 hours. So the NCLEX says 4 to 6. So whatever option that you get on the NCLEX, it's going to be in the range of 4 to 6 and you're golden. But this is not something we want to do in the initial post-procedure care, so we would not select this one. Then palpating their pulses every 15 minutes for the first hour. And yes, that is, if you guys can't tell, the focus of care for this patient is we are constantly assessing for signs of bleeding. And we're going in every 15 minutes, checking their pulses, checking their groin site, looking at the monitor, making sure they're not bleeding or having collapse of that stent. So you guys are right. Our correct options are 2, 3, and 5. And average score was 2.4 out of 3 points on the bank on this. So you guys got it. Well done. All right, now we're going to take action, or something happens and I need to actually figure out what will I do and take that action. So if I generated the solution that I'm going to maybe monitor for electrolyte imbalances, I have to take the action. What lab will I look at? What assessment finding am I actually trying to find? So how am I actually going to implement this option? I need to remove extra fluid from them. How do I do it? How do I safely give this med that I prioritized? So in this case, we've got diagnostic results for a client who became unresponsive and has no palpable pulse. We go into the room and observe that they've got gasping respirations. And this is what you see on the monitor. So which action should you guys take? And I'm going to check and see if I've got any questions from anybody while I give you guys a second to drop your answers in. I keep trying to say guesses, but obviously you guys aren't guessing because you know what you're talking about. And if you miss one, you learn from it, and that's okay too. All right, everybody's guessing 1. All right, Princess Hannah, Lisa Bling, Mayboy, Tisha, you guys are guessing 1. All right, so let's talk about this. Yes, in this scenario, the only information you need to pick this option is this one. They have no palpable pulse. If you can't feel a pulse, and the ACLS actually says if you aren't sure within 10 seconds if you can feel a pulse. So if you're like, I don't know, I'm nervous, they're unresponsive, I'm a new nurse. If you're not certain that you can feel a pulse within 10 seconds, you start chest compressions. It doesn't matter if their monitor shows something. It doesn't matter in this case that they even have gasping respirations. Those aren't normal respirations, and this is a pulseless patient. And so starting chest compressions early is the best thing that you can do to restore the pumping function of the heart and start to return blood flow to the brain and all the other organs that are actively dying with every second that you wait. So why would I have no pulse, but look at this on the monitor? Hannah said no pulse. Exactly, Hannah. So this is something called PEA, pulseless electrical activity. You guys might have learned your H's and T's: hypoxia, hypokalemia, tension pneumothorax, thrombosis. There are a ton of things that can cause the heart to continue to have an electrical signal, but not to actually pump, which is what would cause you to feel a pulse. So we've got PEA. We initiate chest compressions because we don't have a pulse. IV push atropine, that would have been useful if I had bradycardia with a pulse, because then I just need to increase the heart rate and atropine would do that. But it's not correct in this case because I have no pulse. Obtain a 12-lead EKG. No, I already have enough information. They have no palpable pulse. Once I get their pulse back, maybe I'll do an EKG, or if I'm coding them and can't figure out what's going on, maybe we'll get an EKG. But if I do it before chest compressions, it's just going to delay care longer and more of their brain cells will die. So this is maybe correct eventually, but not right now. And then delivering rescue breaths with a bag valve mask. That is something that would be appropriate to do if you just need to give respiratory support to someone who has ineffective respirations or really slow respirations, but a pulse. If they don't have a pulse, they need chest compressions. So good job, you guys. And 56% about got this correct. So you guys who got it are ahead of the curve. Well done. Then finally, after we do everything to help meet our patients' needs, we need to evaluate outcomes or figure out, did it help? And that can include evaluating whether their vital signs changed, whether their labs improved, their assessment findings improved, or it can mean evaluating whether our teaching or our interventions were effective. And so here we're going to look at teaching. And now we've taught a client who's scheduled for a total laryngectomy. Which of these statements by the client would require follow-up? Meaning, which of these statements that they make requires me to correct them or address that misunderstanding or re-educate them somehow because there's been a misunderstanding. So we're looking for an incorrect understanding of the teaching. And if you don't remember what a laryngectomy is, you can just kind of piece together the word. This is from the larynx, which is your voice box, and an ectomy, which means removing something. So this is a removal of the voice box. I will have to practice using a mirror to care for my stoma. Is that a correct statement? Okay, you guys are guessing 4, not guessing, sorry, you're answering 4. I don't see any questions for me, just correct answers. Yeah. All right, so no one's selecting this one, which would be correct. We don't want to follow up on this one because this statement is right, that they would have to practice using a mirror to care for their stoma. This is a big body image change for these patients, and it's important that when they go home, they've kind of accepted this new part of their appearance and they're comfortable looking at it and handling it and practicing. So yes, that doesn't require any follow-up. That is correct. When I'm discharged from the hospital, I won't need the feeding tube. Yeah, that's correct. We don't need to follow up on that. They are going to be able to feed themselves, swallow, and everything just fine. It's just going to affect their larynx, not everything else. Their husband has brought some scarves to wear loosely over the stoma. This is okay. Again, it's a big body image change, and if that can help them accept it, that's completely fine. It's completely safe as long as it's not too tight. So they're wearing it loosely. They're going to be able to not constrict that or cause any infection. Very good. So you guys are correct. This is the thing that needs follow-up after the surgery. My voice will be hoarse, but will eventually return to normal. This means they clearly don't understand the risk of the surgery, and we would probably follow up by getting the healthcare provider to come talk to them again before the surgery because their voice box is going to be removed. They're not ever going to have a normal voice again. We might be able to do some like voice prosthesis, like you see here, where they can intermittently occlude the airflow and generate something that sounds like speech, but it's going to be a little robotic. It's not going to be their normal voice. So we would want to make sure and address this by having that corrected. And again, wow, 41%. So this was not as familiar to most of our users as it was to you guys. So well done. Very good. So that's all I have today. You can find us here on all of our socials. And I have a little while longer if you guys want to ask any questions for us, but you guys did so well. And yeah, you guys did really well. I don't think I've ever had like at least 80% or higher correct answers on these. You guys did so well. Thank you for joining us. Please go check us out on our socials. Check out those cheat sheets. I think you guys are really, really going to like them. Students love those because we're all about studying smarter, not harder at NCLEX Bootcamp. And so we're not going to overwhelm you with way too much information. We're going to give you just the need to know and make sure that you know it really well. So hopefully those of you that came in at a 0 out of 10 readiness feel a little bit more prepared to take the NCLEX if you were going to take it tomorrow. All right. Foon says this was very helpful. You are welcome. Sai wants to know, do we ever feel confident? Sai, you're going to feel confident after you've passed the test. But the more you practice with NCLEX Bootcamp, the more likely you're going to feel confident before the test too. So it's possible. Just keep kind of taking you can take our readiness assessments. I think it gives me a lot of confidence to see that I have a very high chance of passing. So you can go take our first of our 4 readiness assessments for free on NCLEX Bootcamp's website. So go check it out. All right. Yes, he says, yes, you will pass. I think so too. Esther, you don't need to worry. Just stick to the last week of the study schedule and you will be fine. Okay, you guys are so welcome. All right, Portia wants to know, does tetracycline need to be withheld from patients with low platelets? I don't think so, but you can go check out our antibiotics cheat sheet. That doesn't sound like something that's familiar to me from there, but definitely go check out our tetracyclines on the antibiotics cheat sheet. All right. Okay, thanks everybody for coming, and we look forward to seeing you next time on our next webinar. Have a great day.